Okay, so we might make a start. So welcome very much to the first webinar in the Implementation Science Community Practice Series. So just to introduce that for a moment, a number of you I know from your names are part of the Translational Cancer Research Centres funded by the Cancer Institute, and the Cancer Institute has funded or has a working party around implementation science and a community of practice, and I'm leading the education community of practice. So in this area we're really trying to build capacity across translational cancer research centres in implementation science, but also reach out to friends and colleagues in other areas and disciplines to come and work with us. And we run a number of activities already. Some of you may have been lucky enough to come to the Jeremy Grimshaw workshop that we had last year that was very successful. Charlotte Pointeau, who's been talking to you about this webinar, is the convener of the, or the organiser of the community, and we'll be sending information out. So I certainly encourage you to register at that website if you haven't done already. So we'll be running a series of activities out over the year, including a series of webinars. So today's webinar actually kind of grew out of a number of conversations that Carrie Marr and myself have had over the last year, I think probably largely in a coffee shop, around the kind of intersection of implementation science and implementation science and quality improvement. Before I get onto that, I'll just do some housekeeping that I was meant to do, I forgot. So if all attendees are actually muted at the moment, otherwise it gets too difficult to register people in. You should be able to see in your controls that you can type in questions. So we encourage you very much to type in questions as we're going through. We'd like this to be interactive. You also should have a hand tool. So if you'd like to actually speak, you can put your hand up, and if you have a microphone, we can unmute you to ask a question. Charlotte's in the room with us, so she can manage that. So back to the conversation. So my name's Tim Shaw. I'm a professor of eHealth at the University of Sydney. I'm director of a research centre around implementation and eHealth in the Faculty of Health Sciences. I also lead translational or the implementation component of the Translational Cancer Research Centres in Sydney Catalyst, and also work with Sydney West out at Westmead. My colleague, who you'll see in a little moment, is Carrie Marr. Carrie's, as you'll tell from her accent, from the UK, and is Executive Director for Organisational Effectiveness in Western Sydney, and brings a wealth of experience around how the National Health System approaches quality improvement. So, as I was kind of mentioning before, instead of this just being a lecture on what is implementation science and what is quality improvement, we really wanted to start to talk about this intersection, which is coming up increasingly now, between implementation science and quality improvement. Both of these disciplines are really quite young. They're within a single generation, I guess, of practitioners, and the heroes of both groups, or the grandfathers and grandmothers of both groups, are still with us. So there's people like obviously Grimshaw and Grohl in the implementation science. You've got Don Berwick and Pronovost and Lucian Leap in the kind of quality improvement side. So there's quite new disciplines, the two of them. I said here that they're different planets with the same aim. I think both of these groups certainly look at improving outcomes for patients, but I think they come from quite different origins and quite different focuses. And something that Carrie and I have been talking about, and I know others are around the world talking about this as well, is how we can really work together to bring these together. I think in our particular context as well, where a number of us are working with these large translational cancer research centres, and also with the emerging academic health centres at most of our major teaching hospitals, I think this is an opportunity for us to come together. So I know when I started looking at implementation science, there was just a mass of terms that started to come up, from implementation, translation, diffusion, then you'd hit Lean, Six Sigma. It was unclear to me when I started how all these fitted together and what the interrelationship with them is, and what's the difference really between the implementation science and some of the more quality improvement end of the spectrum. I'm just going to give a couple of slides now on how I see implementation science, its origins, and and where it's been going. Then Carrie's going to give a brief conversation around quality improvement in its main points. Then we'll come together at the end and hopefully have a discussion around that. So I guess this is a much used definition of implementation research. So there's a few key words here. I guess it's the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice, and hence improve the quality and effectiveness of healthcare services. So it's coming from that kind of scientific kind of research angle, I guess. These next few slides, many of you may have seen. I guess it's the motivation for the translational research end. We all know, any of us that are researchers, National Health and Medical Research Council, ARC, and others, are really starting to push us down towards this making sure things go into practice. I thank Eva Grunfeld, who was here recently, who lent me these slides. So I like these kind of valleys of death between basic biomedical research, where we know of only 100 major findings important for human health, only 5% of them are translated for human use. Then we also know that only 14% enter into standard clinical practice, only 1% lead to important health impacts. So I think in the translational or the implementation end of the research, this is the space we're really looking at, is how do we get this implementation into practice. And then this is where I think we really need to talk about how we work with the quality improvement people, because that's where they started. Translational research tended to start down the other end, but I think it's fair to say that quality improvement actually starts down at this pointy end in the health practice space. Briefly, the way I've approached this in my thinking around how medicine's worked over the last 50 years or so, I think that really we've had the era of evidence-based medicine perhaps since the 1990s to present, which was all about discovery, clinical trials, creation of guidelines, and that really went on for a number of years, over 15 to 20 years. I think what's happened now is that really there's increasing evidence that a lot of those discoveries and even what gets through to trials and guidelines really is not getting into practice. There's obviously papers out recently, such as Jeffrey's paper around the primary care uptake of evidence, and a number of other papers suggesting that really we're not getting this evidence into practice. And that certainly, I think, grabbed the attention of government and funding agencies. So to me, that's what's really led to the implementation of, or the creation of implementation or improvement sites, which I realise I just spelled wrong there. So I guess the little dotted green line to the left suggests it's been around prior to now. It's been around for at least 15 to 20 years, but I think it's this impetus that it's now got that's driving it. And really, I think what we're looking at now on the implementation side is managing data analytics, looking at where the gaps are, really engaging with the system and the clinicians, and applying and evaluating interventions. And then obviously we need to have a conversation between the evidence-based medicine, which is still really important, but how that evidence then is continually linked with the implementation of that evidence. And to me, that's the research space and the overlap with quality improvement, which I hope we'll discuss a bit more in a moment. So I have to show this slide. This is the model that the Cancer Institute uses for translational research. Again, it's interesting. I don't think quality improvement people would look at this, but it's really showing this T1, T2, T3. And anybody that's been in translational research will have heard these Ts by now. And so we're really interested in being in the T3 research into implementation space. Before I hand over to Carrie, I thought it'd be worth just mentioning some of the frameworks that are applied to support implementation research. Many of you will be very familiar with these. We obviously have Richard Grohl's framework. He recently published that a couple of years ago now in a book, which I find very useful personally. We have the Canadian Knowledge to Action cycle, which is what we base a lot of our work on. We have Sharon Strauss, who's one of the creators. That was out last year and is coming out here again this year. We obviously got Mishy's work with her behaviour change wheel, which was also useful. And then I think many of us use the BMC framework in our work, where we start to talk about kind of phase 1 studies through to phase 2 trials, through to phase 3 randomized controlled trials, using a lot of the language that's used in the clinical trial sphere to apply to our implementation work. So just very briefly, here's Mishy's wheel. For those that aren't familiar with it, I find it's quite useful in terms of taking a holistic approach to how you can change people's behaviour. She has policy categories, kind of intervention functions, and then the actual sources of the behaviour. That's a useful framework. And then we have the model for translational research from Canada. I kind of definitely put this one in because it overlaps a lot, I think, with what Carrie is going to talk about, which is really the kind of PDSA cycle, where we're coming to ensuring that you have this cyclical kind of approach to change. So you don't just do it once, you have to keep kind of coming back and evaluating and changing. Well, I think what's different is this isn't short cycle so much, this is a kind of a long process of moving around. But many of the features of this, I think, are starting to be reflected in the quality improvement side. So should we slide this down? See how that works. So I'm going to hand over now to Carrie. So here you go, that's Carrie now, hopefully it's on screen.
Morning everyone. So I'm going to give you a flavour of the quality improvement approach, and then we'll kind of get into a conversation about where the connecting points are. Tim and I think there's quite a few. I've started by offering you a definition of what quality improvement is. Now, the reason I picked this one is because there's certain things that jump out at me that are quite important to our approach. The first is the fact that it's about systematic and continuous actions, and for us in quality improvement, the model is all about reliability. So what we want to be able to demonstrate is whatever we do, we're doing it for every patient all of the time. And at the moment in healthcare, that's not something that we can say. And the second element of the approach that's fundamental is measurable improvement, because if we can't measure it, we can't improve it. And therefore for us, we need to look at the quality of the data that we have available in real time that will enable us to measure how we improve. We ask ourselves 4 questions in healthcare delivery if we are looking at improvement. The first is, do we know how good we are today? The second is, do we know how we benchmark with the best? The third is, do we know today where our waste, variation and harm is in our service, in our patient pathways, in our organisation? And the fourth is, can we demonstrate our rate of improvement over time? And that's only measurable, not anecdotal. The model of improvement is fairly fundamental to our approach. It asks 3 questions all of the time, and it offers a PDSA cycle so that what we do is on a very local level with patients, we aim to act on that PDSA cycle. And for us, the cycle is a repeated one. So we go into this with a very clear aim that improvement is iterative and it's going to take time. And you know, for some improvement pieces of work, we may be doing 20 plus PDSA cycles in order to get to something that we think we want to hold on to. So for us, it's about engagement, and the model for improvement gives 3 questions that clinical teams will all get engaged and interested in relation to the patient pathway that they want to improve. Our typical approach historically has been to come at these wicked issues and these problems in quite a traditional way. So our old model used to be perfection. We would all go into a room, we probably know these as working groups and committees, and we would attempt to design solutions in a totally separate environment from where the patient was. And we wouldn't go into the patient environment to test it. We would get to a point we felt it was perfect, and we would implement it. And in some ways, this is similar to a compliance approach. We kind of expect people to do something because we produce it. What we do know is that doesn't always stick. Your teams need to be engaged in knowing what they're doing is the right thing. So the approach we use in quality improvement is much more like this. So we start having an initial design. We think about the 3 questions in the model of improvement, and we take that into the real world of the clinical environment. And our approach is always to think about testing with one nurse, one doctor, one pharmacist, one physio, and one patient. So it starts very small. Our proposition is if you get it right and test it with one patient, then you can spread. So the test and modification in the first stage will always start with one patient. Then we move to 2, then we move to 5, to 10, and we spread. It's quite a disciplined methodology, but we do find it works. But the other thing that makes it work is it's all done by the teams that touch the patient, not by people in a different part of the world. And because of that, the engagement not just of the clinicians but the patients is really, really strong. And from that, we found that we have more sustainable improvement outcomes. So these are improvements that stick, because one of the biggest challenges we have in healthcare is that we make a lot of improvements, but we don't sustain them. I thought I'd give you 2 examples from Scotland, because you'd never guess I come from there with this accent, because we've been using this methodology for over 7 years. We have a mandatory patient safety program that runs across the whole of the country for every hospital, every community service, every mental health service and paediatric service. And at the early start of our work, we realised data was really important. So all of our staff involved in quality improvement programs are all taught about measurement and real-time data. They're taught to use the tools of driver diagrams, and they're taught to use run charts. And we found this totally changed how we looked at data. We started by looking at averages. We started by looking at one dot, a process measure. And we ended in our patient safety program, which is still running, where every day people are looking at the rate of improvement over time in a run charts in relation to their clinical service. So does this work? Well, we think it does. This is the conversation that we're having in Western Sydney at the moment about how we can take this methodology and approach and use it to embed patient safety. In Scotland, we've had these kind of outcomes now 6 years into the programme. These are sustainable outcomes, and these are across the whole country. So it does take time. It's taken us months to engage clinical teams across every hospital in Scotland, but we've had months where across a whole country we've had no central line infections. And for us, you know, that shows that what we're doing is really being taken on board and is being owned by clinical teams in a way that's very, very different from how we traditionally practiced. Now I'm going to hand back to Tim.
Great. Thanks very much for that. So I mean, I think I've kind of lived in the 2 worlds of safety and quality and implementation science, and so for me, I think I got a lot, even again, from that talk about, you know, lessons that we can learn from each other. I mean, if we go back to the different panelists again, I think you kind of agree that obviously the origins are quite different here. So I think it's fair to say with Lucian Leap and Don Berwick and others, that are kind of the godfathers of safety and quality, it kind of came from that kind of needing to change at the coalface. I had an interesting conversation at IHI in Boston a year or so ago, where I think that whereas the implementation scientists tend to come from the academic side, a bit more kind of pointy-headed perhaps, rather than kind of engaged at the ground. But kind of who cares about this? I was looking at this other than groups like us that are trying to combine, and there was recently in 2013 a a major implementation science conference from the Journal of Implementation Science, which is, I guess, the Bible for implementation science, and in that they actually reached a consensus recommendation around this need to actually work out how implementation and improvement sciences do intersect, so that we can learn from each other, so we can have the kind of rigor of the implementation science combined perhaps with that really nice hands-on engagement side the quality improvement has. I just drew up this little kind of table here when I was kind of comparing these in my own head in terms of what the kind of differences are between implementation science and quality improvement, perhaps. That's obviously our illustrious university down the bottom. So I think it's fair to say that implementation science often academic-led, whereas Carrie really made that point that quality improvement comes from within, it has to be driven from within. Although I think at times quality improvement, perhaps as it becomes its own discipline, becomes an office within the organisation, I guess there's a danger that too can become somewhat removed from the practice as well. I think implementation science has this kind of rational scientific side to it, whereas I think quality improvement certainly is perhaps more passionate and engaged. I think the implementation science is often made as part of a larger program of work, whereas the quality improvement is more responsive to the kind of focus on local issues. I think that the implementation science has a focus on the methodology and evaluation. Quality improvement has a very clear methodology, as Carrie just described there, but I think it's a real focus on patient outcomes. I think implementation science, although both focus on data, I think the implementation science really focuses on that, getting that really rigorous data that will allow you to get the NHMRC grants, whereas quality improvement is about getting the data that will allow you to show change and demonstrate that to the teams to encourage people to actually engage and go on more. I think a key point here is that for implementation science, the reward is around academic output and academic, I'm not sure where I meant times there, I meant grants, I think. So whereas the quality improvement, the reward for people engaged in quality improvement is improved patient outcomes, kind of metrics that pass across the dashboards of CEs in hospitals and local health districts and so on. Implementation science projects, I think, in organisations are often led externally to that organisation. I sometimes use the analogy, a number of you may have heard, that I think often implementation science projects, because of the timescales, are often thought up at least 18 months before the actual project gets going. Then you have to apply for the grant, you get it. It's almost like a film crew turning up to an organisation where they go in, they do a study, everybody acts slightly differently because they're there, they then pack up at the end of that grant, move out with their data and perhaps leave not a lot behind. Whereas I think in quality improvement it's all about coming from within with that short cycle internal. But obviously there's a natural tension here, and I think we can kind of learn from each other with that. I thought I'd just finish before we go on to discussion around the model I think that we're trying to get out at Sydney West. So this is with Paul Harnett and his team, and with Pam Probin, who's the research manager out at Sydney West. And obviously this is where Carrie lives, out at Westmead. So I think this is where we're trying to develop this model around multidisciplinary teams and then blending quality improvement and implementation science. So I guess I put this forward as a model that may be of interest. When we're looking at the multidisciplinary team at the moment, here there's little P's kind of moving through. I guess they're the patients, but often when you look at an MDT, I feel that really it's a fabulous group of clinicians coming together, multidisciplinary team, but all they really focus on is those individual patients moving through. They spend time with each of those patients, that patient moves through, the next one moves in and that discussion occurs. So it's very individual focus on those patients. What we're starting to look at now at the moment is saying, can you throw a net, more of a net around that and embed the MDT in a larger process that perhaps has a population or cohort focus on those patients. Then what we're trying to look at and saying, if you have good audit and feedback data associated with how that MDT is performing, then you can start to give that data to the clinicians and make this a major way of starting to have change. And what we're finding from some of this process, and some of Carrie's team has been working with this, where we've actually combined implementation scientists and quality improvement people. So the quality improvement redesign people have been coming in, working with the MDT teams, looking at process mapping. And then what we're finding from that is we're getting a kind of a combination of quality improvement projects and implementation science research questions flowing from that. And then we're working out how we can work together to combine those kind of projects. So some of them will select for kind of rigorous evaluation, others will go through for more quality improvement. But at all times we're trying to use in our implementation science approach some of the methods of quality improvement, so making it engaged, short cycle and so on. Then I guess really the aim we're trying to achieve with this is to come out with it with an integrated continuous quality improvement process and research output, because we're within an academic health centre, but that's kind of pulling in the same boat rather than sailing in from different directions, I guess is how we'd like to look at that. So that's the end of the formal presentation. Now, we're very happy to take questions if people have questions. So if anybody wants to raise their hand, I'll move back slightly. And Carrie and I'll try. Carrie's looking a bit stiff, but we'll sort that, Carrie. I think it's fair to say this morning, so I appreciate you coming in. So hopefully people will still be able to hear us as we move back there. So Charlotte, are there any questions coming in?
There's no questions, but we've got Kim's got a hand.
Oh, Kim. Okay, so Kim. So we'll try and unmute Kim. So, can you do that?
They can't be unmuted, actually.
Oh, they're on the phone. So Kim, we can't unfortunately unmute you. Perhaps you can type your question in. No, we can't unmute Kim. Okay, so I mean, Carrie, maybe we can have a little bit of a conversation around this. So I guess oh, there is a question.
Yeah, we just had a question. It's how might we bring the two closer together, Tim?
Well, look, I mean, I think for me, one of the first things is I've realised that many of you know Sydney Catalyst has been doing quite a lot of work in the lung cancer space, and it kind of dawned on me, this with Nicole and Sarah and others, that we hadn't actually really approached the quality improvement people within the organisation. So, I mean, I think we hadn't gone and knocked on their door and said, hey, look, we're in here, we're trying to do these systems redesigns effectively to evaluate how these things are, how we can improve them. But the group we had gone and approached is the group that's kind of commissioned to do that within the organisation. And what I actually found when you do, and what Carrie and I have found as we've talked, I've been talking to members of Carrie's team, is that quality improvement people are actually really quite interested in the research and want to engage with that and not just look at the kind of more of the kind of reactive side, and I know that's very much where you're going, is to be kind of proactive. So I think one of the things in response to that question is to actually go and talk to the quality improvement people and start to say, how can we work together, how can we make these happen? Carrie, I don't know whether you have any to add to that.
Yeah, I mean, I think if you speak to staff, staff think at the moment there's almost two exclusive clubs. There's the research club and there's the improvement club. And you either join one or the other. I think our proposition is it'd be great to get staff engaged in both. And so that would be the first thought. I think the second is that, you know, our team has never connected with the researchers, and so we don't even know where each other live. And so there's a bit about trying to have more of a connection with the people who know the science of implementation and improvement. Get more connection and discussion between each other, and think about how we can work together on some projects. Yeah? The improvement world is always based on evidence. Ventilator-acquired pneumonia is based on an evidence-based approach. So is a lot of other interventions. At the moment, we'd love to do some research on culture, leadership, and team effectiveness. So I think there's lots of options to it.
Okay, well, thanks for that. I mean, I think out at Westmead, it's been an interesting relationship. I think there's been some suspicion's not the right word, a lack of understanding from both sides about how we can work together. And I think the time scale is one of the real challenges in this, because implementation projects tend to take a very long time. And by the time you actually get your funding in that, the clinicians that may originally been interested have either retired or moved on to the next project. So I think some of that is a challenge to have that kind of, I think that's why I'm really happy with the translational research centres, because they've given us that longitudinal length of funding to allow us over 5 years to actually build up a rapport and a relationship such as the relationship that Carrie and I have are developing over the last year or more. There were some other questions coming in. I saw one about Tracy, but maybe just before we go to Tracy, I think there was a question there about how do we make it not. You see that question there, hamper both approaches. How is this dealt with in Scotland? I guess that is that all there is to that question?
I think so.
Hard to read it. I guess that's saying if you combine, do you kind of the need for ethics can ethics. Look, this is a real challenge, the ethical question. I agree with that. I think it's just something you've got to deal with. So we put in ethics for the work we're doing with the upper GI team out at Westmead. Obviously, quality improvement projects can move faster because they don't need to go with ethics. But look, I can't deny that this is one of the challenges we face. I think the ethics process at the moment, I hope, is going to evolve into something that can cope with this better. I think that at the moment it's way too slow to allow us to do this. If we are coming together, I think we probably need to engage with ethics to enable this to happen. And I think a lot of the research we're doing is pretty low risk, and I think we need to start looking at that, how we can make that work. But sure, that's a problem. Do you want to go to Tracy before? Maybe we can attempt to unmute Tracy. Hi, Tracy, you're unmuted. But maybe you don't have a microphone switched on. Okay, well, we'll leave you unmuted, Tracy, and you speak. You work out if you can speak in.
Otherwise, you can feel free to type.
Yeah, type your question in if you can't get your microphone to work. So then there's another question. Given the overlap between implementation science and quality improvement, should projects in these fields go through institutional ethics or through institutional quality assurance processes? Again, I think that's probably a work in progress. Carrie, do you have any comments on that? I mean, ethics perhaps isn't something you have to worry about so much in your space.
No, we don't. And I suppose the assurance that the organisation takes from quality improvement projects, and you know, I kind of move away from calling them projects. I mean, this is work. This is the day job of teams. That it's the data that assures that we're doing the right thing. If the data in real time shows that we're improving those outcomes, then that's good enough for the healthcare system. So I do think it is a different approach, but you know, not one that we might not find ways around.
Yeah, no, I agree. So look, I mean, I think that's obviously a challenge. You raised a really interesting point there, Carrie. Though I think about the data. I think that's going to be one of the things that really brings us together. I think as we get to much more real-time data, that allows the implementation sciences to work in a shorter cycle as well. One of the great challenges we have in implementation science is getting good data around what we're doing, and I think that's one of the lengthy processes there. And I think the access to that data is going to make this work a lot easier. On that point as well about how we come together, I think something that Paul Harnett's doing out at Westmead, which is interesting, is he's created Insights Not Hunches working party within the Cancer Centre, and it's I don't think Paul would mind me saying it's a bit of a kind of a social experiment almost in terms of bringing different groups together in the quality and the implementation side to discuss these issues and start to say how can we look at the questions that are coming out of quality improvement, select some of those for deeper research, engage both of those partners in, so quality improvement people are on the publications that come out of that are actually active members of that research team and get those rewards as well. But then we understand how we can go through and work with those teams to engage with those clinical people in a kind of timely manner. So that's a bit of an experiment underway, but we'll certainly be looking at how that evolves.
And can I maybe add something to that? So the added value of looking at it at a very local level, like with the cancer service, is that all quality improvement work happens once you start looking at the data. The best way to work out where your biggest improvement areas are is to see what data you've got in your services. And so the conversation that we have locally around the data we've got is really important. What we've never done is done it jointly. So what Paul's bringing together is quite innovative, I think. and actually quite transferable to think about how we can deploy expertise from two parts of the system to help clinical teams in that conversation.
Yeah, no, I agree. And I think we do, and then I think you need some projects to work it on. So I think the fact that Paul has now selected the upper GI team to be working with around that, I think that gives you the vehicle to really test bed these. So there's another question there. We might try Tracy again. Hi, Tracy.
Oh, can you hear me? Oh, you can hear me now? Hello? Oh, thank you. Look, I wanted to thank you both because you've really progressed this model, but I'm really interested to know from Carrie, like from my observations, a lot of the quality metrics that we use relate to hospital lengths of stay or readmission rates, and I'm just wondering, sometimes I think that intersection with QI, what other metrics can we use, I suppose is what I'm interested in, to demonstrate that we're improving.
Okay, so the debate is about how you can add more granular metrics to the ones that we're required to report on. A lot of what we share is process measures. So length of stay is a process measure. It doesn't actually tell me a lot about the quality or the reliability of care. And so if you look at quality improvement at a team level, what we'd be doing is that team would be identifying their own metrics. So what are the things that they need to be showing over time? It might be certain interventions. So it might be about how quickly and reliably each patient is assessed the minute they come into an ED or an acute medical unit. It might be about the team conversation about that patient. It might be about leadership. So there's lots of technical and team behavioural and effectiveness measures that we would put in there. And I'm happy to share more, because it's almost a conversation in itself, and we could certainly give you some examples. But the difference here is aggregated data that we share is at organisational level. Our proposition is the data that a clinical team holds and the metrics and the priorities for improvement that they identify are actually the more important ones. And that's what we work with. Does that help?
Thank you. Thank you so much. That's really interesting. Thank you.
There's a couple more questions from Megan. Hi, Megan. So Federal Department of Health is experimenting with embedding academics in their primary care branch in a KE role. Has anything similar been done in clinical settings, embedding implementation science researchers in clinical settings? Look, I think that's a really interesting question. I think the TRIP, as you mentioned, the TRIP fellows and Merrin Finlay, I'm supervising this year as a TRIP fellow, and that's certainly something we're looking at. So that TRIP fellows are NH and MRC funded clinicians who take a half-time role for 2 years to implement a process. Again, it's interesting about how much they're engaging often with the quality branch. But this is something that came out of the research we've been doing out of Sydney West, is this concept of an embedded person, and I think that's a good idea. So it's done in the basic science space very effectively. Some of you may know Anna DeFazio out at Westmead, who's a very well-respected researcher who's embedded in the MDT. So she's a basic scientist sitting inside the MDT, and I know that when we've interviewed Anna, and this sparking that happens between Anna and the team in a positive way around idea generation is very good. We've certainly been playing with that in the idea of the quality improvement. Whether you can embed quality improvement members within the team as well to turn up and also have implementation scientists there as well. That's certainly something we've been playing with. Time's a real challenge with this. There's lots of MDTs. Can everybody go? Is it worth having somebody sitting in those meetings? Or in fact, what do we actually need to have extraordinary meetings held outside of the regular cycle? One of the challenges we've been having when you look at multidisciplinary teams is just the pressure on those teams to get through their panel of patients. So certainly one of the things we've been looking at is having a quarterly research and improvement meeting where that's dedicated to that, to allow that to happen. And that happens in, say, the melanoma team at the Melanoma Institute very effectively and others. So I think, Megan, in that space, I totally agree. I think embedding those people is a really good idea. We'd like to do more of that. I was recently in the States, and I've been dealing with some improvement fellows, I think that's what they're called. They're a new intervention at Dana-Farber, where they're taking some young clinicians and giving them a year to be an improvement scientist, which I think is really interesting. It's being done in other places as well, and I guess we're looking at opportunities for that here. But again, instead of them just making them quality improvement, I think if you can create a fellow like that, then you make them part of the implementation research team as well as the quality improvement team, so that they get their publications out of it and so on as they move through. So yeah, I think there's models for that. Cecily, yeah. Oh. Are there strategies for sustainability once a project no longer under the microscope? Huge problem with implementation science, I think, personally. I think this is one of the great problems with this, that so much of the implementation work is done, and because it's done outside of the context of making it normal practice within the organisation, it doesn't get taken up. But I think Carrie would say that part of your whole life and generation is trying to ensure that sustainability. And I know with the 100,000 lives and the 10 million lives campaign in the US from IHI, that's certainly been a key feature. Would you want to comment on that? Or maybe both those questions.
Yeah, I mean, this is quite an important part of the whole approach. So sustainability comes from culture, is what I believe. Those teams that keep their improvement and their reliability going do it because it's the right thing to do, because the team culture is orientated to safety and improvement, it's part of their daily conversations, they value each other's role in that work. And so for us, the teams that have sustained in Scotland have done it because they own it and they drive it in the culture of the team at a local level. And if you look internationally at the organisations who are in the top quartile for this kind of work, that's what they all do. So our approach is as much about local leadership, culture, team effectiveness, as well as the technical interventions around safety. And that's definitely what makes it stick. People will not sustain improvement if they are told to do it and it's prescribed. They will only sustain it if they own it, and it's part of the culture of that team. So.
That's great. Look, and I think that inherent in Richard Grohl and the Cape Knowledge to Action cycle in Canada is to try and make that link and that sustainability. I know I've had a number of conversations. I've been lucky enough to have them with Richard Grohl, and that, he certainly sees this merger between the implementation sites and QI, and I think that's reflected in his writings and books, and that's to allow that sustainability. So I mean, I think again we need to work together so we can do the rigor around those interventions to work out which matter. But then when you're into practice, that's when you use the tools and techniques of the QI to kind of make those actually sustain and work within your organisation. I actually think the Cancer Institute itself is an interesting body, that it has two wings itself. It has the service delivery redesign type group and then the research that it's funding in its own right, which is quite unique. And I know that Sancha and others are looking at, Mary are looking at how those teams work together, because I think that's a nice kind of microcosm, if you like, of what we're trying to achieve, to bring those, so we still have quality research that will get into the next Cochrane review in implementation science, but is engaged with the service delivery end so that we get sustainable change within our system, which is what the motivation of the cancer plan is within the Cancer Institute. Okay, so look, that's it for questions. I hope you found that useful. I guess Carrie and I have been feeling our way along this relationship and in how we make these come together, and Paul has been as well with his team out at Westmead. So, and I should acknowledge that Tracy and Anna and Kylie and others have been really working on that with us as we've moved through this program. So I'd be really interested if people want to join in this conversation with us, and email me. It's tim.shaw@sydney.edu.au if you'd like to be part of this. If there's interest in this, we may cycle back through these kind of ideas. Maybe we can present the work we've been doing with the upper GI team as that progresses and evolves, so that we can share our experiences with that. Carrie, any final comments? Or?
No, I mean, I think today's about an invitation to continue the dialogue. Tim and I would love more people to join the conversation. We think it would help if we could connect this in a way we've never done before, and we're looking for your ideas and your help to do that. So we'd love you to email Tim if you'd like to continue this conversation after today. Thank you.
And I just finally say by encouraging you to register for the implementation community practice if you haven't done already. And maybe if you've got friends in quality improvement, that's what we'd like to do, to engage them, reach out and get them to be part of that community as well. I think I'm really tempted to call it the community of improvement science, which is the term that's coming out of the UK from the Health Fund, which I really like. I like the idea of improvement science because it's kind of includes, it's a bit of both, which is really what we're talking about. So maybe we should look at renaming ourselves. Anyway, on that point, we'll finish up. It's 10 to 9, so thanks for spending the time with us this morning, and we look forward to seeing you again soon.
Thank you.
Thank you.